virtually, I will, the tech is set up so that you can join and observe only. Please remember everybody around the table to speak up so that we have good audio for those in the room and on screen. And if we are joined by people on screen, we'll keep an eye on. If we are joined by people on screen, I will ask you to raise your hand and introduce yourself when you're about to speak, so that those remotely will be able to have that benefit as well. And I must also say a welcome, and my apologies, Susan, for not having welcomed you properly at the start there, who's here in place of Rachel Schmidt, the local authority member. Thank you very much. Minutes of our board meeting, please, on the 19th of November and matters arising. We have minutes in the pack for approval. Please, could I ask members to offer any comment? And if not, to approve these as a matter of accurate record of the meeting. Approval, thank you. We will then move to our declarations of interest. Are there any new declarations or declarations pertinent to the subject matter for today's meeting? Our current register of interest information is included in the pack, and the nature of our board with partner members means that there are inherent risks of interest because of the organisations that they lead or are part of. And so these will be pertinent in items 7, 9, 11 and 12. But all reports from this meeting in public are for assurance and discussion, not decision. And so the level of conflict is manageable, and as the perspective of all members is important, all may participate in discussion. Thank you to all our partner members. We'll move then to questions from the public. As this is a meeting in public, not a public meeting, where possible, our presenters are going to answer the questions as part of their presentations. What we do is to answer the questions that are pertinent to the agenda in the course of the meeting. And there's one question that will be answered on that basis, and that relates to agenda item 10. There are 4 other which are not being covered in this meeting, not part of the agenda for this meeting. So they will be addressed within 20 working days, and the written answers to those questions will be published. Those questions relate to Bob ICB achievements, the entry of new providers into providing NHS services, a question about Great Western Park GP surgery, and privatisation of patient transport services. Thank you. And thank you for the question that's going to be picked up in item 10. I'm delighted then now to move to our resident story, a story that Rachel is going to introduce for us, and thank you. Thank you, Rachel.
Thank you, Priya. So good afternoon, everybody. My name is Rachel Corso. I'm the Chief Nursing Officer here at the ICB. I'm delighted to introduce Barbara, who I've been in a number of conversations 18 months or so, who's shared with me her experience of navigating what at times was quite a complex and challenging experience, supporting the care of her husband David towards the end of and up to the end of his life. So without further ado, I'm going to hand over to Barbara just to know about herself and this journey.
Thank you. And thank you very much for giving me the opportunity to share my experiences with you. And I'm sorry if I wobble. I just will. Okay. And it's nothing to do with you or the setting. So my husband David was diagnosed with advanced prostate cancer in June 2013. He had absolutely fantastic treatment over the next nearly 10 years and was part of the Stampede trial that you may have heard of around prostate cancer, and was on the arm where he was taking abiraterone on top of the normal hormone treatment. And it meant that we kept him for almost a decade. In November 22, he was diagnosed with secondary bone cancer and died 6 months later on the 4th of April 2023. And I think the first point that I would make, this is meant to be a story about end-of-life care. The first point I would make is that nobody actually talked to us about end-of-life care until the very end of the period, when the wonderful Sobel nurse who was leading on the hospice at home care that we had said, you need to get the family back. It's the first time I felt that anybody had been honest about the situation. I got my kids back and he died the next day. So I would say that the 6-month period broke down into a number of phases, and they all had their issues that I just wanted to share with you. So the first phase was when from diagnosis of the bone cancer to having an operation to take out the diseased bone in his thigh. And I would say that the NHS was at its absolute best at that point. We had an absolute barrage of activity that just happened in the most efficient way. Boom, 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 boom. X-rays, consultation with an oncologist, CT and MRI scans, community therapy team came around to offer us all sorts of kit that we didn't know we needed at that point and said no to, and then an operation to replace hip and thigh. And it was really impressive. It's what the NHS is best at, as I was saying, but a big issue in that process was that we were never shown the CT and MRI scans that were taken. So I think had we seen those and had we had a conversation about those, we would have seen that he was already riddled with metastasis, and the operation would have been really tedious to him. And it would have meant that he would have had to face a reality that he didn't really want to face, but he would have had a better 6 months until he did die. Obviously, you can't know how long a process is going to be, but I think at that point it's very clear what the outcome is going to be, and it's not going to be that long. But we were never shown them. And as his carer, I didn't feel I had any place in the conversation to be able to ask to see them so that I could help him to face the reality. So he had the operation on the 7th of December and then had an absolutely terrible 3 weeks in hospital. And I'm sure you great places if you're frail. They're brutal, actually. And he had been told by the orthopod that he would be back home within a week. 3 weeks later, I had to blag him out. Basically, I had to say that it was safe for him to be at home when I wasn't sure that it was, but he was so desperate by that time to be let out. And it was mainly because he had really bad nights in the hospital. They were giving him sleep medication that wasn't working for him, but there wasn't a consistency of care to know that they weren't working and to try other things. There is a little bit of history in this family of odd reactions to different sorts of painkiller or sleep medication. And again, I never really understood that that's what was happening to be able to advocate. All I could do by the 20th was just say he's going, and I'm sorry, he'll discharge himself if he does. So having got him home, we then had about a month of we felt as if we were returning to some sort of normality. It was still slow, he was still tired, but we had a physio appointment to set goals for him to try and move around and do things. And we saw the oncologist who offered chemotherapy that he was very clear was only about prolonging life, not about quality of life. And David grabbed onto that. And I think he should never have been offered it. And in all of that time, I was going from pillar to post, trying to organise all the adult social care support services, trying to understand how I transferred from the community therapy team to the adult social. I still don't really understand the difference, but it's very hard getting transferred from one to the other. And all anybody does, in my experience with those services, is offer you kit. They don't offer you care. If I can be that blunt. Then we had what I think of as his slide down. The consultant also told him when we went for the post-op consultation that he looked 90, which I thought was a bit blunt, but it was true. She was wondering whether she had done the operation on him. We had more MRI and CT scans in preparation for the chemo. Again, we were never shown the results of those. We had a pre-chemo consultation with a new oncologist who was clearly not happy with David being offered the chemotherapy, but didn't feel that at that point he could stop it because it was scheduled for the following day. So he had that chemo session, which was the first and only one he had, and had a really difficult week following it for all sorts of reasons. And at that point, he started on Oramorph. So he's on serious painkillers by that point. So the issue there for me was that there were clear worries from the oncologists about even offering the chemo, but no open discussion of that or visibility of the CT and MRI. And I'm really surprised, given the focus that we've experienced so far on giving the information, that that wasn't shared. And it can't have been any better than the original sets of scans that I suspect were showing the writing firmly on the wall. Then we had a couple of weeks that I will cherish because it was good. The morphine was working, so he was more comfortable. We were put in touch with Sobel House and got onto into discussions with them about how they could support us. We're still struggling to sort out the proper equipment. By the end of that period, David had started to wander. And I thought that was to do with the calcium buildup in his blood, because I've been Googling, you know how you do, Dr. Google. But actually, it turned out to be due to the morphine because he wasn't metabolizing it. Probably, and it was building up. And that meant that he fell on the evening before his second chemo session because he and fell this morning with injuries. He had very thin skin by that point because he'd been on steroids for a long time, and so he just had the skin rolled off quite a lot of. And the nurses, the wonderful nurses in the chemo bit, were very worried about infection getting in. So they thought he wasn't well enough to have the chemo. We saw another oncologist who sent us off to the JR. We didn't get out of the JR emergency department until 11:30 that night. They didn't tell David that they wanted to keep him in. They didn't tell him why they wanted to keep him in. He was desperate to get home. He didn't want to be stuck in hospital again. I had to flag him that again. We were left to get a taxi back at 11:30 at night in very cold weather. One appointment had been arranged until a wonderful emergency department doctor actually took care and rang to say, you really need to go to this appointment at the ambulatory assessment unit, where they told us that what they'd been so concerned about at the emergency department was the morphine had caused David an acute kidney injury, which I'm just astonished that it was allowed to get to that point. I'm astonished that the GP was prescribing morphine and we had no visit to check with such serious levels of pain killing that was going okay. So following the ambulatory assessment unit, we had the wonderful hospital at home people looking after him when he came back, and they were absolutely fantastic. getting it out, getting him onto OxyContin rather than Oromorph. I had to go to the local chemist and pick up OxyContin and walk home with it. I'm still astonished that you're allowed to do that in this country. I think that's endearing in some ways. And he did seem to respond to that quite well, but by that point he was really getting towards the end. I had a wonderful conversation with the hospice at home people at Sobel, who said, we'll put this care package in place, we'll get all the hospital beds and everything organised into the house. We do need to warn you, however, that if this carries on for more than, I can't remember whether it's 3 weeks or 3 months now, but anyway, a period of time, because you can only have that service for this amount of time before you die. And I'm thinking, well, you don't know when you're going to die. How can you set a policy by how long you've been given to die? And in fact, nobody at any point in this process told us, put a time limit on it. So it meant that we didn't get a blue badge until a few days before he died. So I couldn't use that to get him close to the entrance in the hospital. Blah. All of that swung into gear, and I would say the beginning of the process worked really well. The NHS was brilliant at just chucking stuff at us. Prodigal amounts of money, shouldn't have done it, but nevertheless was rated that. At the end of the process, luckily, we had hospital at home and hospital at home, and that was brilliant. So the care at that point was, I would say, second to none. But it took a heck of a long time to get there. And in my understanding, it's not necessarily normal that you would be able to get that. And indeed, the hospice at home partnership between our GP practice and Sobel House had only started the previous September. I don't know what I would have done. I'm still recovering physically, as you can hear. I would have been in a worse state without. And I think the final thing I would say is, thankfully, the wonderful Sue from Sobel made me get the children home. But the other thing that I just wanted to say is that there's a lot to build on here. We know that care, well, in my experience, the care of in the way that it is organised, and I don't know whether you guys are involved in organising, is just brilliant. And it's got to be better valued than sticking people in. I have no idea how much it costs to do all of that stuff. The operation and the titanium implant and all of that sort of stuff. But I bet it was a really terrifying amount of money. And it was a waste. And there was no review as to whether that was a reasonable thing to do, which in some ways is a great thing. It's really not, because it feels to me that in order to be able to offer that for free at the point of need, we fund that, but we don't fund care. We don't fund the people on people stuff anymore. And that's actually more important. And you need people with judgment to be able to work and be supported by a system where they make those judgments without penalty. And then the other thing that I would, which wasn't a health service, but which was brilliant, and I just think might be something to think about, is when after you've got the death certificate, they offer you the Tell Us Once service, where you put one form in and they inform all the government departments and everything's done for you, and you even get a little grant to help you with all the costs and whatever, and you don't have to do it. And it's wonderful. If there was something like that to triage the services, that, tell us once and then we'll work out what's best for you, would be good. And then finally, I've been a bit astonished actually at the lack of care for the carer. And when I'm the CEO of my business, I haven't actually looked properly at the policies in our employee handbook about leave. we have pages about parental leave and about child death. We have about 2 paragraphs for bereavement, and the only thing that you can be sure of getting is 1 day if you have to organise a funeral. Everything else is at the discretion of the employer, and the average taken in the UK is 6 days. I didn't take 6 days. 6 days wouldn't have been nearly enough had I taken it. Nobody from the GP practice followed up to see how I was. And I've had a lot of issues following with what I think are probably cortisol level issues, digestion. I mean, it's been quite a challenge, and I don't know what I've stocked up, which is going to come back on the NHS ultimately. I don't know really how I am. I'm terrified of starting in some respect. So I feel that David could have had a calmer, more peaceful, more honest end to his life if it had been treated as an life, and the purpose of everything was to keep him as comfortable as possible. And if I had been able to take part in that as his carer, to advocate for him and ensure that all of that happened, it would have required change from him as well, because he would have had to accept that he was dying. But at least I could have had that conversation.
Yeah, but thank you so much for your kindness in being able to share with us at this stage too is hugely appreciated. And your insightfulness is going to help us enormously. And we will keep in touch about how it is helping us. Are you all right if we explore some of the issues, if we open up to...
Yeah, I'm fine. And seriously, this is about me, it's not about you.
Well, your ability to help us despite that is very much appreciated. Colleagues, comments and questions, things that we'd like to explore with Barbara. Sim and then Sandra.
What you were telling us, because it's learning for us as well. Some of us haven't been through that, and it really begs the question for me and for this board is to better understand our end of life provision across our patch. I have to say that I'm not aware of that. At some point maybe I'll need to access those services, whomever. So I think 2 things for me: we understand better our end of life provision and then palliative care within that, and we know the government is thinking funding has gone in, but it would be interesting to see what that means for us. And then the second thing is what I call sort of population knowledge, our knowledge of you know what that means, what it could look like, and we can only learn from people like you. That's why it's so important to hear. So now we can begin to advocate. We can begin to talk about what is expected and what isn't, and push back. And it strikes me we need a more joined up service. So I think that's what I've learned from your story, and we will take that back and really investigate what else we need to do. Thank you so much.
Yeah, thanks, Barbara. 2 things for me. The first thing is I really want to echo what you were saying. I remember caring for my mum through her end of life and thinking, the last time I was in hospital, had anything to do with hospital, was maternity. And it was really clear this was something at that stage, and if that was not quite going right, then we'd go off down that direction. But I knew the whole way through what to expect, and it couldn't be more different from my mum's care. So I'm absolutely, completely with you. And yet I think it can't be that unusual. Everything she was going through could not have been the first time for people. So why aren't we thinking of it that way? Second thing is just really a commitment. I'm the workforce director, so the bereavement bit I think is a really important point. So I give a commitment to make sure we pick up on that for our staff here.
And then Margaret and then Tim.
Thank you so much for sharing. It can't have been easy, and I hate to say this, but your story is one I've heard before.
I'm sure.
And that kind of medicalised model you have in the NHS works really well in the diagnosing things, and I'm glad you had great care there. But where we tend to struggle, overly medical model we have is, I think, in some of those communications, some of that linkage. So I wrote 5 times, I think you talked about different types of communication results: prognosis, care planning, support services, GP, care, 6 things. You know, most of it was all about communication, and I think honest communication. I think we can be honest as a clinician. Some clinicians find it difficult to have those honest conversations. You know, and I think we need to do that. And I think we need training, we need finding, but that's going to be really easily predicted. The exact prognosis, but we can give an indication. You know, a common question some of us like to ask is, well, this is where we are today. This is what's happened in the previous 3 months. If we carry on like this, this is probably where we'll end up. You know, it's those kind of sensible working with somebody conversations that I think that you're sort of highlighting, as well as some of the challenges around accessing support services. So yeah, thank you for doing that. I think there's things we need to take away and reflect on. And yeah, I'd go back to just thinking, you know, you've clearly told us some really helpful things. You know, community care was really helpful. You know, made a big difference to your the end of life. Nobody will do too many interventions. And that's something I think we should.
I do just to say though, I think that stems from the fact, I think a lot of the time medics are deeply optimistic people, and it's quite hard for them. And also we become believing that you can solve anything, and to even a thing such as death. So I think there is something about when we have that conversation as a society.
Well, that was so brave. 2 points I thought about. One was on values, and it was values in the medical profession about journalism and honesty and so on, but values in decision making. And being kind can have many manifestations, and it's not necessarily the most often, you know, more treatment, more expenditure, more services. So that really resonated with our role. And the second was the very last thing on our agenda today. Some of the work that we're doing in committees is talking about end-of-life care and how cash-strapped the voluntary sector is, and how much the NHS depends. You had nothing but kind words to say about hospices and so on. And you have just brought to life that one sentence, which is a risk for us. It's a risk for our people, our populations. It was, you know, luckily David got the help and support. But I think it's worth just anchoring that in committee, that someone said earlier that the charity service isn't a free service, but it is really cash strapped, and those services are under real pressure. So thank you for many things, but you really made that point for us. Thank you.
Thank you.
Tim.
Well done, Barbara. We had a bit of a chat before, so I just say brilliant, well done. It's really good to hear. I had a very similar situation 2-3 years before you with my wife and I as well. And some real similarities and some really big differences, which is interesting. So I lived in Buckinghamshire by about a mile,
Right.
but the hospice we went to, which was Survivor, so slightly different, but was similarly brilliant, was in Oxfordshire. And that in itself brought some interesting fun and games, if you can imagine. But there was lots of real similarities, which is interesting, but some big differences. I think that in itself is a big takeaway for me, for us, I think. The variability, and it was not just because of the people involved and the challenges the individuals had, but how the system, in quotes, because it isn't one system, as we all know. But really interesting. I think that's important that we think about that variability and how can we try and bring the standards up and disseminate the best way of doing these things. But thanks so much for sharing. Really good.
Pleasure. Thank you very much.
Thank you.
Barbara, thank you. I remember vividly when you and I met about a year and a half ago, and you had kindly shared your story of David with me, and I was struck then by picking up Amit's point that a lot of what you described resonates with other patient stories I heard, but also how at times we get things so right in terms of the care we deliver, but at other times we get it so wrong, and how we struggle to actually join things up and provide a package of care to the patient and his or her carers that's easy to navigate, that's easy to understand. And that's one of the reasons why I was so keen for you to come and speak to us as a board, because the ICB has in its gift the ability to commission and plan services that hopefully will go some way to addressing the points that you powerfully made today. So I'm incredibly grateful, and I can only echo what my colleagues have said. You know, the way you described that was probably the most powerful patient story I've heard in my career.
Oh, wow.
I've heard quite a few, so thank you so much.
I'm really disappointed that I kept on nearly weeping.
We're incredibly grateful that you persevered. And I know you said that you've not actually told that story in that way because you're doing it for us, but the way in which you've been able to really hone in on those things that are going to help us make change, I think is enormously helpful, and enormously commendable that you created that clarity for us. So thank you.
Oh, thank you for having me. I really, despite appearances to the contrary, I've really enjoyed it. And it means a lot to me to be able to offer David's experience in a way that might help. We were incredibly proud as a couple of being on the Stampede trial, and the extent to which that's helping people around the world now. And I do think one of the reasons why we didn't have that clarity at the beginning was because his oncology team was so proud of people. And I just think it was very difficult for them to give up on that. Yeah. So I do appreciate you guys have got incredibly difficult jobs. I don't know how you do it. I think you're all total heroes.
But you're helping us, so thank you.
Pleasure. Thank you, and I hope the rest of the board is great.
It's a great meeting with more helpful insights and more helpful folks. Fantastic to have Barbara here, and I'd be very keen for us to keep Barbara up to date with how we are looking at those areas and what differences has influenced us to think about. That's very powerful. Offering kit, not care, is something to hang on to, isn't it? Thank you very much, Rachel. Rachel's not back in the room, but to support Barbara to tell that for us, I think it's really helpful. We'll move then to our Chief Executive and Director's report, and over to you.
Thank you, and for those I'm Nick, I'm Chief Executive of the Integrated Care Board. I like to take my reports as read, just want to flag and then I'll hand over to Abid, who is our Chief Medical Officer, and Rachel, our Chief Business Officer, just to say a few words in relation to their particular portfolio responsibility. Firstly, beginning with the change programme, paragraph 5, the restructuring of the Integrated Care Board as an organisation is progressing as planned. I'm pleased to report. As of the 1st of January, Simon Grant joined us as our Chief People Officer following interviews last year. Simon's been with us for a fair few months now as Deputy Chief People Officer, so there's been a seamless transition and handover from Caroline Corrigan, who was our Acting Chief People Officer for about 12 months. You'll see that 96% of our staff are now based in suitable roles across our new structure. The report says that 21 staff who've yet to find suitable alternative employment. That figure has actually fallen since this paper was produced. I think now 19, if my memory serves me right, and we're hopeful that a fair number of those will be found suitable employment over the next few weeks. We still have approximately 190 vacancies across the organisation, The executive team met yesterday to go through those vacancies and agree those which are priorities to recruit, and now move forward recruiting to those priority roles, of which there are about 40 and 50 across the various directorates. Obviously, we'll talk a bit more about operational pressures later on today's agenda. Just wanted to thank colleagues both within the organisation and across our wider system for the work they did over the holiday period. Was the case, it was a very busy time, not least to high rates of seasonal infections, especially flu and COVID. I'm pleased to report that Bob as a system coped reasonably well with the operational pressures which are ongoing. Linked to that, there's been a lot of focus in recent days on elective performance. So that's sort of the routine aspect of healthcare work, operations, outcomes, etc. Prior to Christmas, the Prime Minister stated the government's commitment to ensure that 92% of patients should wait no longer than 18 weeks from referral to the start of consultant-led treatment for non-urgent health conditions by the end of this Parliament. Ambitious targets have been set to get to that point, and you'll be aware on Monday last week the elective reform plan was launched by the government. This sets out a number of initiatives to try and increase elective capacity, including the expansion of community diagnostic centres, of which we have 3 in our system, one in Cowley, not too far from where we're meeting today, one in Thatcham and one in Amersham. Plan is the opening hours of those centres to be increased, along with the variety of tests that can be performed at those centres. Additionally, there's a plan to increase the number of elective surgical hubs across the country. Yet to see what that will mean for us as a system. I think linked to this, there will understandably be a laser-like focus on elective activity and how we are performing as a system to reduce the number of patients waiting for elective care. We do have some significant challenges in one of our providers in relation to that. And again, we'll pick that up in the performance reports as part of today's agenda. Moving on to specialised commissioning, colleagues will be aware that the NHS England Board prior to Christmas approved the regional plan to transfer commissioning responsibility for 70 specialised services to integrated care boards. Work is ongoing in relation to this, being coordinated by the Frimley system. I'm very grateful for the efforts of Sue Writing, who works for the ICB, who's working closely with Frimley colleagues in preparation for this, and we will, as a board, receive a paper that we'll need to consider for ratification in March this year, as the other 5 systems across the South East will. I mentioned Sandra's arrival. Very grateful that she's joined the team. I can also confirm that we've appointed a new Chief Medical Officer. Ben Riley will be joining the ICB on 2nd of March. Ben is a GP by background and currently the Executive Director in Oxford Health, responsible for their community, primary care and dental services. He's been in that post now for about 5 years. He's been a wealth of managerial and political experience, and I've no doubt that helped strengthen the leadership of the ICB. In the meantime, Abid will continue to be our Chief Medical Officer. I'm very grateful for Abid's continued support. I also just wanted to make board colleagues aware that the Senior Information Risk Owner responsibility has now transferred to Hannah Iqbal, who is our Executive Director responsible for strategy, transformation and digital directorate. This is an important role in terms of the organisation's information governance. And I'm very grateful to Claire Doble, who was occupying the role on an interim basis following Kathleen Manford's retirement. With Planners Directorate in mind, the new directorate came into being on the 1st of January. It brings together a number of core functions for the ICB, which I think are absolutely critical to our ability to successfully lead the system, not just strategy, transformation, and digital, but also communications and governance. And the directorate met as a team for the first time last week, when Claire was able to outline her vision for the directorate and clarify the benefits of bringing these teams together. And I was also able to contribute and outline my vision for the ICB, which is how key I see the directorate as being in ensuring our success. I think that's all I want to say by way of the short updates. I'll tell over to Aberdeen University.
Thanks, Nick. So a couple of updates from me, links to the conversations we had at our previous boards on the pressures and funding across different sectors. So the first one is around primary care. So the Secretary of State announced a funding uplift for general practice specifically for the next financial year. It's equates to approximately about 4.8% uplift in the overall budgets, but we don't know exactly the detail of that or what the ask will be or what's included in that. Other matters related to red tape. So there's a big kind of review going on at the moment about reduction in bureaucracy or what colleagues are asked to do across the sector. So we'll see the outcomes of that, and I suspect that'll be incorporated in the contract. More flexibility around the using of the additional roles reimbursement scheme budget. So one of the announcements is to extend the use of that monies or additional monies for newly qualified GPs. So those were the first 2 years. So they've got jobs to come into and help the crisis and workload. So that's positive, and there'll be other flexibilities in there as well. There'll also be a reduction of specific targets. So primary care has something called quality outcomes framework, which is specific targets for pieces of work in specific areas. So there'll be a consolidation of those, I understand, and focusing on the key things, maybe prevention, cardiovascular, and yet to be decided. So that's good. So freeing up more time for frontline care. And I understand there'll be incentivization of continuing care for specific cohorts of patients. So for example, frail elderly or complex patients. So either the same GP or the same team. So again, improving outcomes for that specific cohort. So that's all good news. And as I said, the contract negotiations are ongoing now, and then we'll hear those over the next 8 weeks or so of the outcome of that. Just linked to what we've been discussing, so welcome announcements regarding funding for hospices as well. So 26 will be for children's hospices, which is really good. So it helps them to continue to deliver the excellent services they provide, as we've just been hearing from our kind of resident story, and the infrastructure they need, services. So that's really positive. Other good news story is that in line with the national ask of increasing urgent dental appointments, in addition to what we already deliver, the ask was 700,000 appointments across the country, our share. And we're pleased to announce that we've commissioned additional 5,000 appointments from January to March. So that's really good that we advertise through access pharmacies and will be allocated through NHS 111. So that's really positive. There's a really good uptake of that. So we'll be thinking about how we can utilise our dental funds to perhaps improve those and going into the new financial year as well. Just briefly further down in the paper, there was a note from Bucks Health Watch Buckinghamshire did a specific review around the experiences of our vulnerable population around migrants, and they 28 people, we've got in-depth interviews and their experiences to understand how we can improve services. So there's a couple of things in there that I summarise where, for example, difficulty accessing medicines, whether they're going back to their home country when getting medicines imported, or navigating the system or not quite understanding how to use specific services, the NHS Act, for example, how that system works. So they had a number of recommendations, some for the local authorities, some for the ICB, which something from the ICB point of view would support, and getting information out there about use of the app or services and access to medicines and so forth. So we will do a formal response to that, but in principle, they're supportive of the good work there and recommendations. One final thing I just wanted to update, it's not in the paper, just verbally update the board on, was around something that we had a legal claim that was sent in to the ICB around offensive waste, reprocurement of offensive waste services. So the ICB is required to commission collection of clinical waste for primary care, something that's always done. And actually all ICB contracts around the country were due to expire at the end of March. So the decision was made to go out along with all the number of other ICB ICBs 23 in total, to use a third party called Ecovate to run the procurement process for us and manage this on behalf of us and other ICBs together, which seemed a sensible decision rather than trying to do something independently and use the collective resources. So the process had actually completed, and a number of ICBs have declared their preferred bidder. We hadn't actually, we were just about to take that decision. But unfortunately, a claim was issued against not only Ecovate, but I think in total 22 ICBs with action around in relation to this process. So, as I said, we hadn't actually declared our preferred bidder, so we will be holding off on that at the moment. Our legal team have been working capsticks, we're going to be acting jointly for us and the other ICBs. I think Ecovate will be separate lawyers, and we were working together as a cross ICB working group to kind of manage this going forward. So it's just to update the board that we have got a kind of a plan of action to see make sure that the contract doesn't come to an end, and with that come the end of March. So working with other colleagues and the incumbent provider, who's actually the claimant in this case as well, to see whether we can make sure that there's we can extend their services or find alternative arrangements if services. We'll do the board for and colleagues briefed and things like that. So all these litigation matters, it may well take a few months before matters are sorted and settled. Think Rachel, yes, Rachel.
Yeah, thank you, Abid. So just a couple of points from me to add into what was in the report around what's commonly and affectionately become known as the CODdemic. So the impact that COVID, flu, norovirus and the respiratory syncytial virus is having on our populations. And some of our partners are significantly affected by this and less so. However, on a positive note, the teams have worked really hard to ensure that we're delivering a wide variety of access to vaccinations, which is, as we know, is our biggest form of defence against some of these viruses. And just under 80% of our eligible population of over 65 have received this year's seasonal flu vaccine, which is higher than the England average. And I'm sure whilst it feels tough for our partners providing services, we are comparably doing better than other areas, and I'm sure that's a direct correlation with that. Some work to do in vaccination uptake in our 2 and 3 year olds, and we're delighted that our vaccination rate, particularly for the new respiratory syncytial virus in our pregnant women, is really positive. An area of focus continues to be around our healthcare support workers, and whilst we are having a higher than England average in uptake in healthcare support workers of just under 35%, it's still much lower than we would want it to be. And there will be some work done nationally in how we look at lessons learned this year in our vaccination programme, particularly as we start to prepare for what is already an ambitious spring vaccination campaign, and already starting to think about what the winter vaccination campaign for 25-26 will do. And we will do that alongside our public health partners as we go into the new campaign.
That's it. Questions?
Thank you very much. Comment and question, please. Tis and then Mark.
A very quick one for Abid. With regard to the migrant questionnaire or investigation, the communicate, it was the issue that, I'm not sure it was slightly different, but the general view, was it that the migrant population or those that were interviewed were not eligible and didn't understand their eligibility to dentistry and so forth, and medicines, or is it that they were eligible and were able to understand how to access them?
I think it was the access issue, maybe either being aware of the services and then specifically access. I'm not sure, because when the report said that those who did access it then weren't eligible for treatment for cost purposes, but I'm not sure about that. It would have been free anyway, so yeah. I didn't quite get that point. So that was what the report said, and we would obviously investigate that. But we have got specific part of the flexible commissioning scheme we've been commissioned last year. Specifically, it's there for these vulnerable population groups and dentists, and
So who's leading on the fixing the communication issue? Is that an ICB issue? Is it a GP? How's that? Who owns the solution, I suppose, on game?
So I think it's certainly working with the dentists, making sure that patients. So either working directly with the specific communities, because sometimes they concentrate in specific areas and they target those, and certainly at the comms point of view, make sure that they're aware of getting the information and working with the dentist so that it's clear from both parties, both sides.
Thanks, Ellie.
Question for Nick or Sandra, I don't know. It's about the new risk on workforce that has been added as a high risk from early January, so 2 weeks ago. And I've seen figures ranging from 170 to 200 vacancies. Just want to flag that because in population health work, we've seen shortages in several skilled areas in the clinical sphere. So just some assurance about control measures at the moment that it's down as red. We haven't got any control measures yet, but just some background to that.
Yeah, so,
I'm really suggesting you go.
so the session we had yesterday, the executive session was going through what should our next scope, our next scaling of the vacancies, recruitment to the vacancies be. So we did a whole exec team look at all of those vacancies to agree the priority areas and what risks are we dealing with, where are we covering roles that actually wasn't working, where do we need to now go out to permanent recruitment. So that was done yesterday on a kind of a risk and priority based thing. So there'll be about another 50 roles that will be coming out. But it is something that, so if you can see from that risk, we haven't quite done all of the controls measures and assurance on that yet. So that's something that we'll be bringing back to the next call.
So will the specifics be raised to people committee or population health in the next month or so, just so we've got an eye on where the highest risks are with those vacancies?
And just before I bring Susan in, you wanted to come in on the same.
Just on the same point, Margaret, and really to that assurance point, which is, that's a high number of vacancies, isn't it, if you consider the size of our organisation and the ICB. And I suppose we wanted to flag it because obviously there's a capacity issue in terms of delivery. So it's the phased approach that's being taken, which will sort of mitigate the risk areas. I think, Sandra, you're very clear on where those divisions, where the need is greatest in terms of delivery and operational. And so that's
the other bit to add to that is then a lot of these roles are being covered through interim basis. So the work we did yesterday was clarifying which roles are remaining priority, even if they are being covered now, permanent recruitment. But we can do that. We're doing that scoping exercise about where exactly we're at now, given the latest kind of at-risk recruitment that we've been going through. So we can absolutely share that on a themed basis, if you like, so it's not individualised.
So Tim just wants to come in on that same point, then Nick, and then
just very specifically on this point about filling the recruitment and prioritising, which is obviously the right thing to do. Do we have a specific date by which we aim to have those vacancies filled? Because if we don't say it's the 31st of March or whatever it is, and the people may not be in post because notice periods, etc., but a date by which we are targeting that you'll have named individuals to fill those roles by. If not, my experience, it will just be an aspiration and it will drift.
Yeah, and we have to phase this with what's manageable for any one organisation. If we're going out for a third of posts to come in to the 2/3 of people that are here working at the moment, it has to be a manageable position. So the next phase will be between February appointments. February advert ready for April, May appointment time. And then we'll be going through that process of what should the next phase look like, etc. So all of that is modelled. I guess going back to your point, Margaret, I'm wondering about whether people need to raise specific areas of concern, because it sounds like we need to match the two things. If there are specific things you're concerned about, how do we raise those issues rather than us taking that whole organisational look?
Yeah, and I guess it's correlating or triangulating with population health rates, looking at the areas that we have flagged. So cancer services as well. So I haven't got the answer. We've got about 7 areas that we've flagged. Yeah. But I don't understand if the posts are being covered, then why is it a red list?
Not all posts are covered.
Okay.
So it's just about saying where are we? Things like statutory and mandatory posts we've had to cover. In my team, I have 14 posts and 11 of them are covered on an interim basis at the moment because we had to hold all of the permanent recruitment so that at-risk staff could get first call on all of the roles that might potentially be recruitment for them. So it's about managing that whole process through. Yes.
I suppose to reinforce that point, we've been carrying these vacancies now for 12 months, if not longer, as a consequence of the change programme to ensure that we have necessary flexibility to try and retain as many of our people as possible at the end of the change programme. but those roles which are critical to our ability to discharge our core responsibilities have been filled on an interim basis by colleagues on short-term contracts or whatever. So I don't want people to think we've got 170 vacancies with no one in them. And the majority of the roles are covered.
And will appear in our papers.
Thanks very much. Just to pick up on the point we were just discussing there about agency interim converting to permanent, will there be a positive financial implication once the post filled? That's one sort of like question. And then I just wanted my actual question was to Rachel about vaccinations and thinking about whether there isn't a take up, how looking together with the local authorities at those who aren't taking up the vaccinations and how local authorities may help with that, and thinking about that analysis, how that might help in the future.
Can we talk that one? Welcome to that first. I think we're already trying to do some of that deep dive with public colleagues in understand where those gaps are. A lot of the inequalities focus as well has already demonstrated to have quite a positive impact. So we know when we've got some of those areas of deprivation, low uptake, it's working well, then what more can we do? So I think that will definitely come through our inequalities forum that we've got and make sure we link through our
We've got the first question, Susan. I think it's a mix. So there are some areas, for example, that we're covering through the commissioning support unit who've got a cost when we will make savings once we won't recruit permanently. There are other areas where if you haven't got anybody covering that role, it will increase. So it's a real mix there, and that's the scope of it.
Thank you, everybody. That's been really helpful. Thank you to Nick and the team for that. Let us move then now to our strategic planning and system development part of the agenda, which we're starting this afternoon with our Oxfordshire Place update. So over to you, Dan. Thank you very much.
Thanks very much. So I'm Dan Levison. I'm Director for Places and Communities. I was previously Place Director for Oxfordshire, so this is probably the place-based partnership that I can talk most confidently about right now. But when we get to Bucks and Berkshire, hopefully I'll do equally as well. So just to remind people, the Oxfordshire Place-based Partnership is a really broad and inclusive partnership. So it's chaired by Stephen Chandler from County Council. We have Grant and Megan, the chief execs from Oxford Health and OUH on the partnership. We have a representative from city and districts there. So we're a two-tier authority, which is one of the distinctions between Oxfordshire and the other two places. We also have 3 GPs. We have Veronica from Health Watch, who I see is sat in the corner there. And more recently, we've also included Eddie McDowell, who is the director responsible for the Care Association in Oxfordshire. So really represents a big part of our provider landscape and one of the ones particularly delivering care in people's homes, as well as nursing homes and care homes. It is an informal forum, so it's a consultative forum. What we really rely on, what we focused on, is developing the relationships and trust and the conditions that are best suited for working together as a system. So just to remind people, as far as the context is, it wouldn't be a place update without a reference to the new operating model. So we have shifted into our new operating model. We have got the 3 appointed executive sponsors. So Matthew Tate, who may want to say stuff at the end of this bit, is the exec sponsor for Oxfordshire. And we're working, it's fair to say we're working through how that operating model's going to work in reality. So it is and I think what we're all recognising within this, the system that we work in, even just within the ICB, is a complicated matrix. And then when we layer on our system colleagues and partners and voluntary community sector and others, it's equally complicated. I think Oxfordshire Place-based Partnership has signalled that they would be interested in appointing a place convener, but that we want to wait and see how the operating model develops. And I think that's the same for other place-based partnerships as well, more or less. And just very quickly moving on to the priorities for next year. So we want to continue to develop the place-based partnership. We do have I think, like I said at the beginning, we have unashamedly focused on the relationships, and I think it's really important to keep stressing that. A lot of what our system relies on is building the good quality system relationships as opposed to formal governance and structures. So we focused on that. We do have a maturity matrix that we measure once a year, so we're aiming to be a thriving partnership. We're currently a developing partnership, and we'll get a measurement hopefully next month on where we are with that, in line with what came through from the consultation, hopefully in the future further delegation of responsibility to the place-based partnership. Priority populations, again, I should have said at the beginning, the focus for us is to only try to focus on people and populations that will benefit from more joined up care. So this is really looking at the people where education, health, social care, voluntary sector working better will positively benefit from the outcomes and better value care. So we've had a big emphasis, and we'll continue to have an emphasis on improving outcomes for children, young people and families with special educational needs and disabilities. From a health point of view, there is a real focus on neurodevelopmental pathways, supporting people from the point of referral, not necessarily the assessment and diagnostic pathways. It's really important that we're supporting families when they identify a need, and really supporting and improving our integrated therapies, which is particularly challenged, and further integration and a focus on early years. So one of the things that we know from our public health data is children eligible for school meals not worse than national average when it comes to school readiness, which is a determinant for health outcomes in the long run from the Michael Marmot work that's been done. So we're going to focus on early years and aim to grow our pooled budget that we have, where we have joint contracts with County Council for children's services, because we feel like we can leverage our joint collective resources better by combining them. Adult and older adult mental health, there's a plan to transform over the next 10 years. We've had an outcomes-based contract in Oxfordshire for adult mental health for the last since 2015. So this is really the next step on that. So it's incorporating some of the services that were outside of that contract and older adult contract, really trying to emphasize as much as possible early intervention and prevention, and not just the treatment of mental health. And so it fits quite neatly with the 10-year plan, and it's really run through a partnership with Oxford Health and voluntary community sector. Fundamentally, housing and the housing pathway is a really important part of that, alongside some of the stuff around employment. Urgent and emergency care, we continue to integrate. It's probably one of the areas we'd say is most successful. I think, again, down to the relationships between social care, the acute trust, the community providers and GPs, and the voluntary sector. So we're successfully discharging more people home, and they're returning to independence more quickly. We're avoiding unnecessary emergency department stays. And what we're again, our focus for the coming year really has to be, we feel like we probably maxed out our discharging capability. There is only so much discharges that our social care colleagues can cope with. So really the emphasis is going to focus on, we need to do much better preventing falls, and we need to do much better avoiding unnecessary or avoidable admissions. So we know there's a handful of people, or quite a large number of people, that get admitted to hospitals that, with the services that we have unable to deliver outside of hospital, and with the greater connection to the integrated neighbourhood teams, we will be able to coordinate their care better and avoid it. But we really have to, like I say, I think from a social care point of view, the care market and social care has done a phenomenal job supporting people in their homes and discharging people, but we're probably as far as we can go without avoiding admissions now. And then the final two are a continued emphasis on working together to focus on upstream prevention and reducing health inequalities, again linked to what Rachel said, the working with the 10 most deprived wards and growing into, so what we've discovered again with public health is a lot of the hidden inequalities. So while the 10 most deprived wards are well known in Oxfordshire. There's a lot of the neighbourhoods and streets within wards that aren't necessarily in those places where we know that there's a lot of deprivation. So growing that work, continuing to work upstream with those communities, continuing to work with the voluntary community sector. We've got a big emphasis, and I think we've had a presentation here before, on increasing activity levels. Just the Move Together programme, which is for older people, particularly in deprived areas, has increased activity significantly. It's also demonstrated a reduction, over 50% reduction in GP attendances for people that participate in the scheme, reducing 111 and 999 calls and reducing falls. So there's a lot, and it feels like, again, within the 10-year plan, it feels like increasing activity levels is going to be one of the things that as systems we want to focus on. And then finally, our contribution to system productivity and efficiency. I think we need to probably be a little bit more demanding of place-based partnerships about our contribution to savings and efficiencies. I think we have identified what we can do with community equipment services. There's stuff that we can do and need to do around our section 117. Again, because it's a joint responsibility, there's things that we can do at places that we're probably best equipped to do at places. And some of the stuff that we need to get into around continuing healthcare and the management of the market. So yeah, those are our priorities, and I'll hand over Matthew if you wanted to add anything.
Only a couple of weeks, I think you've really held up summary as always. So I think in terms of the exec sponsor role, as working with Rachel and Ben with Community MA, we're working for our reduction programme. So I've got sessions booked with most of the place-based partnership members over the coming weeks, and we'll adopt a senior role for Rachel and Ben. And we're working through operationally which sessions, which boards we need to attend to make sure we've established that stakeholder relationship. I think you'll see in your work programmes the importance of the delivery vehicle that is place-based partnerships. But what we've seen already with Dan's role is the benefit of having more challenge between the place-based partnerships and the work programmes by having Dan's role in place. So I think we are in a good position to protect the good things about place-based partnerships, think about how we design them in terms of delivery vehicle, but also make that connection with planning and new director and that comparison. I think on the productivity and efficiency front, I think we've got multiple examples, I think, where we've done that already. But actually, to your point earlier in the workshop, we've got probably get slightly better at what are the metrics that we're tracking alongside this delivery. Happy to take questions.
Thank you both very much.
Thanks for that update. So just on that point, Matthew, that you were making, and Dan, you sort of mentioned as well, in terms of how challenging, I guess, you're going to be, Dan, in your role, what does good look like for a place-based partnership? And I guess it's something, we'll be discussing and thinking about. But I guess if I know what good looks like, it'd be good then to see the relative strengths and weaknesses of the three place-based partnership. Once you've had some time, obviously, to get to know the partnerships. And I think it's important that we're honest with the three areas. And it's not about having a league table necessarily, but I think we've got to learn, haven't we, from one another and be honest about our weaknesses and be able to work from what others are doing in our patch.
I'm sure Dan may want to come in, but I expect the work that we've done in some patches around the maturity matrix, and Dan will probably have more in Oxfordshire than perhaps we've done in Bucks and Berkshire West on the detail of that matrix, good measurements. I think we need to be cognizant about, as Dan mentioned, some of the stuff about relationship management does achieve results. It's how we articulate that in terms of measurements of outcomes, and the value of that relationship piece is challenging, but I think we need to work to. Dan, did you want to add anything?
Yeah, I think you've probably got a sense of it from me anyway. I think the ruthless focus on relationships is really important, and something that when we started out on it, I think there's something really important about a genuine partnership. You're either in a partnership or you're not. It's not a conditional thing, and I think that's one of the things that we've been really clear. Partnership means you're in it, so you can't be in it until, or you can't be in it but. you're in a partnership. So that's one thing, and it's probably a nuance, and it's subtle, but it's an important part of system working that I think we have to be really honest about. When it gets difficult, that's when we need to lean more into partnership working. And I think there is something about being really deliberate about choosing people and populations that will benefit. And I think there's a slight danger, and we see it all the time with scope creep, with all of this stuff. I think just working for the people and populations that we know touch all of us. That's why education, health, social care, that's why SEND makes sense. I think the health inequality stuff and the links that we have through our colleagues in local authorities, through voluntary community sector with those communities is so fundamental. So there's something about being really clear about those people and populations that are going to benefit.
Just to say thanks again, Dan. I mean, you know, I absolutely love this stuff, and I think this slide is the sort of thing that gives us the rocket fuel, because it's such a great set of priorities that really make a difference. It's prevention, it's addressing inequalities. It's all really good stuff. So brilliant work, and we'll let that continue. Just to bring it down then. Point 8, the bit at the end, and you talked, and you mentioned section 117 in here. You also mentioned continuing health. One of the things that I think you might have even said it to our committee about in this area is the differential between the 3 places. And I know this is your new role where you span all 3. What are we doing to make sure that we're taking the best practice, the elements that we can? Because it's not a cookie cutter, everything's the same. I get that. But what are we doing to make sure that, because there are some pretty big differentials in those 2 areas, as an example, between the 3 places. Many of it may well be down to population differences, and there's good reason. But how can we get assurance that we are sort of taking the learnings and disseminating?
Yeah, so it is a good question. I think the variation begins at the very start of most processes. So what we know about is reliable processes for assessment and review is fundamental to it. So I think the centralisation of our assessment and review processes for any of this stuff is going to be really important.
When do you think we're going to get? Sorry. I know it's not all on you. But.
Yeah, so that again, particularly from the CHC point of view, it's not at all on me. But we've got the central CHC team that's already doing the assessment and review stuff, and then the managing of the market is subtly different. But what we've got between local authorities, so particularly Buckinghamshire and Oxfordshire now, is links between our joint commissioning teams. So community equipment service is a really good example where we've started to work on whether we can actually have a single directory across the 2 local authorities and join up with their purchasing. So there's lots of opportunities for us to connect up, and there's an appetite to do it. I think the joint commissioning teams give us that appetite.
Right. Can I just add, just to give you some comments? Thank you for you come back and describe our operational plan for next year on all of these areas. So all the ones Dan's put in his back on CHC, the original Rachel Course, there are programmes across the system where that variation and that challenge or compare is installed in those programmes. So on all of these areas, we'll be able to describe both the local interface, but also the system-wide work that's taken place to try and do that variation and that consistency.
Thanks, Dan.
Thank you. Thank you all very much, Jan. This has been so helpful, and particularly the work on prioritisation, but also the work across that allows us to accelerate our learning, and therefore the best practice from all 3 systems. So thank you for that. I'd like to move us now then to our system planning update for 25-26, and over to Hannah now. Thank you.
Yeah, so I'll take the paper as read and just touch on 4 quick things. So obviously at the ICB, we have a really core part of our role focused on planning and arranging health and care services. One of the ways we do this is agree with our partners how we're going to use our budget. And one of the things that the NHS has struggled to do over recent years, particularly post-COVID, is to do this within the resources available. So we're really clear this year that the national messaging is actually we need to live within the money that we've got, which is a hard message when we're not currently doing that, because you look at it and you think what stops, what changes. But this is the kind of dialogue we're having across our system. So we're awaiting the planning guidance, but we do know NHS England have said publicly it's going to be tougher than previous years. It's going to feel like a funding decrease, even with the additional money coming into the NHS. So in Bob, we've been reflecting on our legal duty to exercise our functions within the resources available. So we've been discussing with all of our partner organisations, what does it look like to live within the money we have? And if we model that, what are the decisions we need to take as a system? And it's really clear, a couple of things are really clear. Number one, this is really hard. Number two, we need really strong quality processes. So Rachel and Albert have been working with the chief nursing officers and medical officers to start to develop some processes to help us think about that aspect. And number three is we can't really afford to carry on the status quo. So we've been working with colleagues to try and develop more data which shows us actually if we take the status quo and didn't change anything over the next 5 years, what would that mean for simplicity? What's then the case for change for doing things differently? What that's showing us is actually in 5 years' time, the health profile of our population will deteriorate. We're going to need more beds, we're going to need more hospitals we can't afford, and as a result, our financial position will continue to deteriorate. So what we're doing now is trying to understand actually what is it that we can do differently across our different sectors and organisations to turn the tide on this. And so in the paper, you'll see a kind of plan on a page of a big piece of analytical work that we've commissioned to help us understand when we think of the population of Bob, what are their current needs? How are these being met? Where's their variation like we've been talking about just now? And basically, what can we do about it? So alongside the kind of mechanics of planning where we fill in templates and we all work out how to kind of make the budgets balance, we're doing this longer term piece of work which says actually in the decisions that we make today, in the next 6 months, the next year and longer term, how can we set our system on a different track? And that's a collaborative piece of work. So we've got some really important workshops coming up with colleagues across the system to start to think about what's our new vision of a sustainable and more equitable system. I don't know if Alistair wants to come in on any of the financial or the process aspects in terms of submissions, but I'll pause there.
Just two things really. Increased messaging from Julian Kelly, the NHS England Finance Director, that we need to submit plans that are within the resources we have. And that will necessitate certain conversations, and we need to highlight where those conversations need to be had. There's a figure in the paper here which we thought was uncertain when we put it in terms of the timing. Figure 1. We've now been told there will be 1 planning submission in late March. This shows 2. That there'll be 1 planning submission in late March, and we'll be asked to go into NHS England during March to have those difficult conversations before we make that final submission. For 2 things. One is we're asked to manage within the resources we have and no more, and we will have a conversation in March about how we do that.
Thank you both. And open to comments and questions. Sicky.
Yeah, on the planning, the finance was discussed at SPC the other day, and one of the observations we had was in what's presented. It may be that there needs to be some sort of feedback loop or an emergency board to actually see what's being presented. So whilst we need to present a balanced budget, how we actually get there and where the difficult decisions and difficult choices might be had. So we're thinking at least at SPC, whether it's through SPC that's done, or whether actually full board. And I think the seriousness and the size of our potential underlying deficit position is such that it probably needs to be full board between January and March. That's the proposal.
And I think on that point, because there is 1 submission and the terms of that submission are clear, and then that should be exactly right. We should be able to accommodate that in a way that allows us to do it within that scale.
If we just add to Kate's point, because I'd say extraordinary meeting rather than emergency, because hopefully it's planned. But to building on Kate's point, which is I think is absolutely right, is we need to make sure the timing is really important. Obviously, the numbers have got to be as robust as they can be. They also need to be such that if the board has got some real challenges to it and wish to push back and ask for reconsideration, and particularly as it's not just about our organisation, it's the aggregation of 5 or 6 other bodies. We need to make sure it's as early as possible, so that if we say, look, we really need to drill into that number there, we've got time to build the team, we've got time to take it away and do something. Otherwise, we're just having a meeting for the sake of having a meeting. I don't think anything wrong. So I'd urge, that we do that and we replace it as soon as we can when it's still useful.
Thank you. I think it's very sensible. Rachel?
Build on Hannah's point relating to the equality impact assessment process. So we described a bit more of this earlier today, but just for board and other colleagues to be mindful of the process that we will be taking and making sure that through our system quality, there'll be a robust oversight of any of the quality and quality impact of decisions that we make, so that we can be really sighted and cognizant of those decisions and how that will impact on our population. And that will be done by the chief nursing and medical officers across the system.
Thank you.
So just to get the conversation, we have a board development session scheduled for the 11th of February. So can we take as an action that we've gone away and find additional board time between the submission date?
Thank you.
Yeah, thanks. So just to really reiterate, I'm sure George has already said this, but from a GP leadership perspective, it's been really good to be part of this group. I think hopefully we've added something of value, but I think a lot more to add, particularly as we look at the medium-term plan and think about the way forward, because I think that community care model will be critical. Yeah, and also just I think in terms of the decisions we've got to make. Got the elective care reform programme, which we referenced earlier. So I think that's also going to be a factor in the direction and perhaps some of the services we might like to change in terms of how we deliver. And I guess it'd be worth us considering with our colleagues and chief execs and strategy directors how quickly some of those changes which the government is expecting can be delivered. Is that a realistic ask for this financial year? It's 25-26, and if so, should we start planning around that? And then, yes, absolutely, withstanding the difficult decisions that have got to be made, I think the impact assessments have got to be clear across all sectors. We've talked about today voluntary sector, palliative care sector, general practice. Often these are the sorts of sectors we feel do receive quite a lot of impact from these changes, and we're just going to be cognizant of that.
Thank you. Really helpful. Good. So we've had this is the interim sort of update on the planning process, and thank you for all the feedback. That's really been helpful. And this then works towards developing the submissions for this time with that medium-term strategy in mind. So much of what we will be talking about will have, although it will be a 1-year return, will have 2, 3, 4 year trajectories around them, and we need to be clear about what we're tracking in year 1. So thank you for that. The national picture, as we know, is that this is tougher than previous years in terms of finances, and much of this will feel like a real-term decrease in funding. Thank you all. Let's move then to developing a new community involvement and insights approach for the ICB. And over to Sarah there and Hannah.
I'll just introduce it and hand over to Sarah. So this really builds on the discussion we just had. We've just said, actually, as a system, we need to make some difficult decisions over the coming years. We need a different conversation with our public, and we need to be really frank about the resources we have and what the best use of them is. That follows that actually we're going to probably have to make some changes across how we run things. So to do that, we've got a really important strategy here, the ICB, and Sarah will share in a moment a new team that we have mobilised as part of our operating model to ensure that we are acting on kind of community involvement and insight. Before I hand over to Sarah, I just wanted to address a question we've received from Roseanne Edwards. It's really helpful feedback. Roseanne is asking us about our communication function, actually, and kind of questioning why it is that from her view, some of our communication is limited to public health messaging around vaccinations and prescription. And she really makes a point, I'm going to read it, that decisions and changes about health provision in Bucks, Oxfordshire, Berkshire West area are extremely important, and we should be able to give up-to-date information on decisions being made, changes implemented, consideration about service cuts, outsourcing improvements, and public consultations. We should also be able to let people know what the reason is for the changes and what the cost will be. And I think that's a great synthesis of really why we're here and what the public should be able to expect of us in the ICB. And just as a kind of reflection involved, the journey we've been on as the ICB itself means that we haven't always done this particular aspect of our function in the way that we would want to. So this is a reset opportunity to really take that mandate as outlined there, take the strategic context that we've set out and think, okay, we've put some more resource and expertise to this. So really, today we want to have a conversation. What are the priorities for the board as we take it forward? So Sarah, could you outline on the approach?
Thank you, Hannah. So I'm really pleased to be able to present this paper on developing the ICB's approach to community involvement and insight. Since the establishment of the ICB, we do recognise that our efforts in public engagement have not always been as ambitious and inclusive as they could be. As a board, I know you all understand the importance of involving the public in shaping healthcare services and policies. And, we are committed to improving our approach, learning from other systems. There's lots of good practice across England, learning from our partners. Local authorities do community involvement and engagement really, really well. And also building on the work that we have done as an ICB to date. The paper does cover some of our activity that we've undertaken over the past year. But moving forward, we really are aiming to create sort of a more meaningful, inclusive sort of opportunity for public involvement to ensure that our residents' voices are heard and also valued in our decision-making processes. I'll take it that you've read the paper. The paper outlines the approach. Also included in the paper a little bit more detail about how we are supporting the government's engagement on the 10-year plan and some of our local plans for BOD. And as Hannah alluded to, as we implement our new operating model, we have invested in strengthening our capacity and capability to working with local people and our communities. So we've allocated dedicated resource to establish a new community involvement and insight team, which sits within my function that I lead, formed just last week as we transitions to our new operating model. This team will collaborate closely with our partners across GOV and across the region and work with local communities to really try and gain a deeper understanding of diverse needs and priorities of the population. And the paper outlines how we achieve this. So going forward, we really want to ensure we're embedding a public involvement approach across the whole organisation, drawing on insights from our partners and communities. When I say partners, I'm talking about I've watched colleagues, the voluntary and community sector organisations that we work with to inform the work of the ICB so that we can commission representatives for them. So I asked the board to consider our proposed approach to developing community involvement and share their views to help us shape this.
Thank you very much. This is such an important and fundamental part of why we are doing what we are doing. So I'm very grateful for the detail and clarity of the thinking that's getting into this at the moment. So Sim and then Rachel and Sakib, I'm confident that we're going to get lots and lots of input.
Thank you, Hannah. And I know this is something we've really missed. Actually, we talked about it a lot, Sarah and Hannah, how we can do this and how we have been organised enough to do it properly. I remember very well the conversation. So this paper is very welcome. And I particularly like the way we're able to send it back to Barbara, because this is about our residents. And something she said that really struck home to me was the honesty bit. And I think that's something that the NHS sort of has struggled with. But external communication is so important. And I feel that sometimes we've misrepresented the public and haven't given the detail, or we haven't been honest with them about why we have to do some of the things we need to do. And I think it's about time, because I think they will be on our side once we can establish why it is we're doing what we do and what the benefits will be, or not necessarily, but the choices we make that they can be involved in. I think the second thing is, what I'm interested in is how this board will, the intentions set out in the paper are strong. How will this board know when it starts working? What is going to be the acid test if we go out into our communities? How will they tell us? What will they say? What sorts of things will have happened to enable them to say, we feel more connected to the ICB. We know exactly what it's for and what it's doing. We know it hasn't had any results yet, or it hasn't touched us fully yet, but we can see well. So how will we go about feeling that, please? Hannah? Do you want them?
Should we gather our questions and then come back down? So Rachel and then Sophie.
Yeah, my point probably lends itself well to yours, Sim, and thinking about how we use the formal feedback that we get from our populations, particularly in relation to when things don't go quite so well. So I'm thinking of complaints, but also the kind of compliments and concerns as they start to come through. And some of that sits still within my directorate. So how do we triangulate the kind of proactive approach to engaging, and how do we use then our formal feedback and complaints that we get, and the engagement we do with health watching, some of the proactive, as we've seen here today, the surveys that they go out and do, and then bring in the feedback from our providers around some of that information as well to inform how we commission and design services for the future.
Yeah, on the interaction with our residents, I was just wondering, say, for example, the Change NHS initiative, how we're going to reach hard to reach groups, how we're going to interact with faith groups, refugees, migrants, homeless, travellers. And then obviously, because there's a group of people that are already doing communication with many of these groups, say councils, how we link in with them. And often, in my experience over the last 10 years, I've found that there are some demographic that are better, they know how to navigate the NHS, and some of the groups that I've just mentioned do not know how to navigate the NHS or find it very difficult to. So we really need to work even harder so that they know what is available to them.
Sorry, Grant.
Yeah, I think it's building that a little. I suppose it's the bit that feels, so for this paper, if you take it for transactional sort of people who use the NHS in a transactional way and use private care now and again, and they might have an operation, but a scheduled sort of walk. But I'm not sure it fully picks up that sort of long-term conditions, depth of expertise. I know it touches on the patient experience group, but I think there's something of that needs to be elevated, because they're the people that are high intensity users and very complex, whether it's people with diabetes or whatever, but people that really interface with us a lot. So it's right to do the population, but I think it touches on it in the patient experience thing. I think the depth of that's really important, and that then sometimes does tie into some groups that find it hard to navigate the NHS.
Yeah, I'll take a couple of things and hand over to Sarah. So I think firstly, to your point, Rachel, there's something for me about the kind of triangulation just across the ICB. Because if you think about all the input we're getting, actually, I now sign off FOIs, and actually that's another source. What you're having complaints, letters, board questions. I don't think we're often thinking about the themes that are coming through. But to other colleagues' points, that's only a subset of the population. So where do we need to be more targeted, driven, and intentional, but then working in partnership with others? And then to your point, Grant, I think particularly as we start to get more specific around what our system strategy is and where we're going to be, what we should be worried about as an ICB, rather than thinking about the whole, we need to then think about what are the programmes of work that Sarah's team can prioritise that we can just do well and get that depth, because I'm not interested in what 1.8 million people think at some very generic level. That's not going to help us in our decision making. Sarah, do you want to pick up on Change NHS?
Well, maybe a little bit more around the insight and how we recognise him and Rachel was saying how we actually use the insight, the multiple resources to, we have Health Watch give us lots of insight reports,
we heard about one earlier from the migrants. We have, like Rachel says, complaints, freedom of information. We have 4 questions. We have so much coming into us, as well as patient experience from our providers. And what we're going to set up in the first instance is a sort of cross directorate to really sort of map out what are all those that insighting into the ICB, and to really try and understand gaps so that we can then focus on the gaps and speaking to different communities who don't necessarily on a regular basis.
Yeah, I'm still thinking about the other sorts of information. You shouldn't forget IMPs. The new MPs, which we have many, are very keen to engage the ICB. I myself met one on Friday, very helpful meeting. So try to harness the feedback we receive from them, and obviously institutions as well. Yeah, but I'm sure they're very keen to be involved in it. So I think they're looking for sort of a single way into the ICB as well. So very happy to do what I can to assist with that.
Thank you. Yeah. Oh, sorry.
No, that's okay.
Thank you. That's really helpful. So we've spoken about our 3 horizons, and we are clear of the not just the benefit, but the fundamental need and value of our residents' voices to shape what the outcomes are that we're all rowing towards, and to give us that understanding of how they're experiencing the current horizon, which is where we probably have the richest data to be triangulated. And the really helpful part that you're building on is the understanding of actually what does the outcome need to look like for populations in those individual populations within that, and then the patient voice and the resident voice in how we get there. So that's really helpful, and I think the way that you're setting out the engagement approach will help us not to duplicate, but really get much richer information about those things that are future facing, because the richness of the information that we have at the moment probably is around current experience. So that's really, really helpful to know. And I think picking up on Grant's point, those who are experiencing those long-term conditions, etc., as we've seen with Barbara today, the value that we've had out of that has been huge, and it is one tiny element of it. So really being able to learn from that's very helpful. And just the final thought that we're not inventing stuff. There are people that are doing this so well. Partner of Susan was here. She was talking about the insight from local authority. That I know from the voluntary sector hat on, that we have such richness already, and our places are our unit of influence. So we will use that really strongly. So thank you very much for the work that's gone into that and the work that it is signalling going forward. Thank you, everybody. We've now had a short tea break. May I please emphasise short? And we are together at, could we ask actually just that we take a 10-minute public break, please? Good afternoon again, everybody. Thank you very much for reconvening now. We are moving to our part of the agenda, which covers operational delivery, and starting with our Finance Month 8 report from Matthew Metcalfe. Thank you.
Thanks, Chris. It's obviously been some time since the end of month 8, so we are already, as you earlier noted, looking at month 9 data, even if they're still flat reports at this stage. So month 9 will come out on the board within the next few days. The picture from month 8 overall is comparatively consistent with where we were in month 7, which is to say overall a slight improvement in the sort of accumulating year-to-date position. As of month 8, the system spent £46 million more than its relevant income. Against plan, that's 25.8 million over what was intended at the time of the original plan, after taking into account the additional deficit funding that we received. So whilst some stability here in terms of the overall picture, there's still a long way to go when we take the remaining 4 months of the year behind the £46 million in order to close that particular gap. And I think everyone would have to acknowledge, notwithstanding the fact that we officially are forecasting a break-even against that plan, that delivering against that original plan is going to be immensely difficult. And all indications are at this stage, and it's fair to say that we're not going to be able to do that. The challenges really sit within OUH and BFT. People will acknowledge that those have been challenged organisations really from the outset of the year. We've had two special extraordinary meetings with the OUH and the RBFT boards through November through December, and we'll continue to have those to help them and get assurance about how what their plans are in terms of delivering against their original plan. So my earlier comments will be in the light of those meetings. The position on the ICB itself, I'd say, is stable at the present point in time. We have got some risks, but also some opportunities. The risks and opportunities are fairly various at this stage. Through month 9 and 10, the critical task is going to be to narrow those points of variation. We've run through those with the SPC committee and really gone through a considerable amount of detail backing all of this. We have been told by, well, there was some sense in which month 9 would be the critical point in time in which we would tell NHSE about what we really thought we were going to do for the remaining part of the year. They've asked us now to do that in month 10, not in month 9. Some rationale for that is that I think we can see clearly where the upsides are, which largely sit within BHFT and Oxford Health. What we're less able to see is where those downsides are and how they're likely to materialise within RBFT and to some degree within AH2. So month 9 will be really important in terms of narrowing those risks and opportunities. Month 10 is going to be critical in terms of how we report back to NHSE. And naturally enough, anything that we do report back to NHSE in terms of divergence from plan, we will have to deliver. Or better, but no question we will have to deliver whatever it is we go back to them with. Now, of course, we're not going to land NHSE with a round of bad news at the last moment. So between Alistair and I, we continue to have conversations with Karen Gagan and through various channels in order to make sure that we outlook is. So that's the INE position. I think underlying the ICB, where we've seen challenges, CHC, I'd say the position has normalised, and we continue to look positively on where the budget is likely to end up on CHC. We are accepting some positive outcomes, at least some positive opportunities in relation to CHC, which might mean that it does be better than planned ultimately. But Section 117 and special placements of various kinds clearly continue to be a significant pressure, and that would also be true within the acute sector too, with high-cost drugs and devices remaining pressures in those particular areas. We have been told quite clearly today that any underspend on the dental budgets, which had been an opportunity we would like to have taken, although NHS has been very consistent throughout the year in saying we're not going to be able to have those. They confirmed again that we're not going to be able to have those, that they will, in all likelihood, take those back. Precisely when we don't know. The pressure on us, I think, there is to continue, as we heard a little bit earlier, in terms of how we can validate the plans that we have to spend money in those particular areas over the remaining part of this year, and clearly the extent that we can articulate credible plans to do that, that will be all for the better. It is also true that in that area, within the pod area more widely, there are overspends, and there's still a question about whether dental underspends can be used to offset some of the other overspends in the wider sector within pod. That was a question that went through at lunchtime. Interestingly, you can answer that. So that's something we need to bottom out shortly. We continue to run significant vacancies, as again people will appreciate, within the ICB. We had a meeting yesterday about, with conclusion of the change programmes, how we go about cautiously recruiting into those posts, having had what's amounted to a freeze for the most part of the best part of this year. We'd already made some concessions around finance, which people will be aware of, where we're just short of 20 vacancies. We've made an agreement to prioritise around 20 additional posts and recruitment to those in the run-up to 25-26. And in light of that, also we'll then begin to consider the other vacant posts and factor those within our 25-26 planning. Those decisions taken clearly in light of the fact that 25-26 is an immensely tough year, as we consistently throughout this meeting, previous meetings too. I'll make a brief comment on capital. It remains, following some fairly detailed discussions with providers, that their plans are to spend all of the capital that they were allocated during the year. People perhaps will have noted some expectation of overspend within Oxford Health related to additional spend on PFI. That may or may not hit, in fact, in 2024-25 for a variety of sort of accounting technical issues. But what I would add is we have been given some additional CDL headroom by NHSE, which, albeit it won't be spent, it'll allow us to capitalise some of our revenue costs into, I include them within capital, but to date at least have been spent within our revenue budgets, and that will release or relieve some pressure on our revenue position in terms of delivering year end. It popped up in the slide that we were looking at with Alistair earlier on this morning. The details of that we had half confirmed, but maybe some more that comes through in that as well. So NHSE regional team are clearly trying to help us in response, for which we're grateful. I think more generally then on capital balance sheets, those issues are relatively straightforward other than one vital factor that we're dealing with at the moment is cash flow within RBT. Again, we touched on that earlier, and we're working hard to find solutions to funding what is clearly a significant excess of spend over their existing plans, which they are finding difficult to fund with their existing resources. We'll report on that. That's all for now. Thank you.
Very clear, comprehensive. Thank you. Can I open now to comments and questions? So, Pete.
Thank you for that, I guess something that I'm reflecting on is obviously through moving various things and non-recurrent events, people are managing to improve their position or at least stay on where they've planned. I think our concern has to be for 25-26 that if they haven't taken costs out in their run rate, what we will look like in April. So I guess that's a concern. And then in terms of transformation funding, I think we need to do things in a different way. So I would say that for the 25-26 funding year, we should try and encourage our partners to support us in the three DASI requests of acute community illness prevention and analog to digital. And even if we have something like a dragon's den of having to bid for money in a certain way, if we don't do things in a different way, we'll end up with the same situation next year. And I think that's where we need to seriously look at doing things in a different way and encouraging our acute partners, which obviously I have some knowledge of with the two I&I style meetings that we've been doing with RBFT and AUH. But I think, for example, I can't remember what they'd got down to, was it 630 extra heads that they're at out of the original 700? They're not quite clearly going to disappear by April 1st. And so how can we help our partners and how we work together as a we, not a them and us, to actually achieve that position?
There's clearly not an easy or short answer to that, but I think those are vital points that we'll have to address through the discussions we've had around. I think there is a point about our run rate going into 25-26, which is with a reported 46 million deficit at month 8, and our knowledge of what is being done to actual run rates through the course of the remaining 4 months of the year. I think the expectation is that, let's say, we can halve that deficit over the course of the next 3 or 4 months. That is probably going to be as a consequence of non-recurrent measures rather than recurrent ones. And therefore, to the extent we've had discussions about really what the underlying deficit is within the whole of the system, I think the 46 million in the month 8 position is an understatement of that, rather than expecting that we can continue to close the gap through the remaining part of the year and improve our run.
Tim.
Thanks, Priya. Thanks, Matthew, as well. Just to sort of build a little bit on what Sakib's already said, and obviously I'm very conscious this is a board meeting in public, and we've had some conversations this morning, and just to sort of make more publicly really that I think as a board member I'd like to support the chief executives across the system and let them know that we know things are very difficult, stating somewhat the obvious, but equally, building what Matthew's just said, and Sakib, the underlying position is very difficult. We're not alone in this. We're one of 42 ICBs, all in very similar situations to differing degrees. It is very difficult, but as we move into the new year, as part of the planning process, we've got to work as a team across all the partner bodies to look at how we can do things differently for our population, for our communities, and the patients and carers out there. We cannot carry on as we are, and that's not doom and gloom. It's a facing into reality. Things have to change. We'll have to approach the services differently, and some of them they move where they're physically located or how they're delivered. But the numbers are very, very challenging everywhere, and collectively we need to help. How do we move that, to take Sakib's point and the Secretary of State's point, moving into more resource into community and into prevention? That means change, and I think we should somehow minute it that the board supports our partner bodies, and we commission a lot of these services ourselves, but we have to do it differently, in some cases quite dramatically differently. And I expect anyone from Health Watch or from any of our voluntary partners who we're going to rely on, change is inevitable. Change can be a good thing. It's not necessarily something to fear, but we have to embrace it, because things are not sustainable as they are. And that's not a Bob thing. It's a nationwide thing, and really urge that there'll be difficult decisions, there'll be some painful decisions, but there will be many of them are necessary, and hopefully with the work we're doing with Carnal, Farrer and other, we can actually improve things for our residents. But just holding on to stuff because we've always done it that way is not going to work. That's all I'd like to say.
Thank you, Tim. And I think so. As a board, we are noting the month 8 position and the indications for. Sorry, Margaret. Sorry, no, question.
Just a question on POD actually, pharmacy, optometry and dentistry. And Albert, you mentioned earlier about community dentistry getting some boost. I just wonder if we shouldn't look at an underspend in POD as an improvement, because those contractual conditions have become less attractive to pharmacies, community dentists. People are handing back their contracts, pharmacies are closing. So is there a systemic problem with our service provision that we need to flag? Because underspend isn't always good, is it? We want our community dentists to be spending. There's a risk here, and I just want to. How can we manage this? Do you think that's a risk? How do we manage that?
I mean, the dental reserves as defined. We need to do the work to refine actually how much of that is. We thought there was quite a lot, but actually I committed quite a lot. We worked hard not to have that underspend, but the system is quite complicated. The way dentists are paid and clawbacks and trying to work out where you are financially in years. So I think we've committed a fair amount of that reserve we have, but it needs validation. We worked hard. The team has worked hard to go above and beyond and try to get that. For example, the urgent access, that's like £500,000 worth of additional urgent access appointments. So we mobilised those very quickly because it was only like kind of November, towards the end of November, that we were advised by a national team that this is something we need to deliver. And most other schemes. So getting that reinvested. I don't think we're actually sitting on huge amounts. That's but we need the work
just to flag, it's great there's been that improvement, but we need to spend that money, right? Have those services,
In general terms, an underspend is a failure to do the activity that we would have anticipated, whereas a cost reduction per item or pathway is to be welcomed because that's an efficiency and improvement. So it will be good for us just to be clear about how we use our terminology there. But I think it is definitely the case that if we anticipate, there certainly are experiences that there's more need than we are currently meeting. So it's unusual to underspend, but the reasons for the underspend may not be immediately able to be tackled, but we've got to have a plan for that if that's required. Are there any other comments or questions? So thank you for confirming the month 8 position and the indications for 9 and the taking stock is the month 10 position. It's good for us to note also the significant work that's being undertaken through the R&I pathway with those of our partner organisations who are most distressed at the moment, and but there isn't a lack of focus on those of our partner organisations who are still making sure that they're trying to better the anticipated position through these last few months of the year. So that concerted activity is noted and welcomed. And coming back to our earlier system planning approach, we are picking up that what is our exit run rate and therefore what is the true consequence of that on entry and opportunity for transformation for 2026. Thank you, everybody. Can I move us now to our performance and quality report? Matthew Tate, Dale Fan and Rachel Cripser, please.
Thank you, Chair. So I'll kick off and confirm to my colleague as normal. And as normal, I will, rather than go through the report, I'll pull out some insights, probably some more live data and recent performance, just to give the board a sense where we are. So in terms of urgent and emergency care, there's always a mixed picture of how you portray this. We have seen a reduction in performance across the board since the end of the summer, which is not surprising. We remain, and comparisons are important in this case. I think it gives an indication of where the country is in terms of general performance. We We remain slightly below, as you'll see in the report for November, slightly below the South East and national average, but actually we're not an outlier in terms of the South East performance. The report goes up to the end of November, but I want to give you a flavour really of how winter has felt. Rachel referenced some of the infection challenges earlier, as did Nick, and we have seen high levels of flu, COVID and norovirus in all our trusts that have added to the winter pressures. We think they've now just about peaked. But in terms of where we are, we had a very difficult first week in January, which is common. But generally, in terms of comparisons across the winter, what we're seeing is better performance in previous years by 1 or 2% generally, and that's a position across the South East as well as our system, and the higher set of attendances. So that does demonstrate, I think, some of our plans have worked and mitigated that issue. And I think it's important to note, given some of the national news around a number of trusts going into critical incidents, we haven't had any of our trusts move into either business continuity or critical incident during this period. The most pressured trust in January would have been RBFT, and we have seen them move into Opal for a number of occasions over the last couple of weeks, and they remain a significant outlier across the South East now in terms of handover delays. And we do need to be cognizant and work on that issue. I expect it may continue to be a challenge until we resolve some of the premises issues at RBFT. The other indication I wanted to give in terms of managing winter, and that we've done relatively well, is there are 5 national triggers around real winter escalation. And just to give you an example, a couple of those are quite extreme. So they're over 8-hour ambulance holds. They're over 48 hours wait in ED for physical health. Over 4 days wait in ED for mental health. Below 30% for type 1 performance. So they are quite extreme challenges. And above Cat 2 average of 60 minutes. So Bob hasn't triggered any of those since the end of December in the January window. The South East has. So I think comparatively it just demonstrates that in some of those metrics we're doing relatively well. I don't think anybody wants to hit any of those. They're quite extreme metrics. And over the South East we haven't hit the Cat 2 one at all actually, so that's credit to our ambulance trusts. And I would finish on urgent care by saying, I think Nick acknowledged the credit to the system. I think we should give all of our system partners credits. I was in a session with Steve and the Berkshire West Unified Exec earlier in the week, and he was really keen to point out how both primary care and the community providers stepped up in their moment of need to really support discharges. So I think that's an example of good system working and good place working in times of extreme pressure. So that's sort of a flavour of UEC. On elective, again, it's a mixed picture, and Nick referred to the elective plan earlier. So we continue to see a reduction in long waits. That's very positive. I mentioned to the board before that Oxford University Hospitals have a particularly challenged position. That hasn't shifted, so we are seeing a slow downward trend in terms of over 65-week waits for Oxford, but they have now been placed into Tier 1, which is the highest tier of sort of national scrutiny around long waits recovery. And Nick has the pleasure of fortnightly meetings alongside me to work with the trust on how we can support that recovery. We had our latest session on Monday, which was the first time we've seen a sort of route to zero from the trust. It does rely on 3 central planks. One is actually additional internal capacity, weekend work in additional lists within the trust, use of the independent sector and good take-up of independent sector support, and then acceleration of mutual aid across. We've made good progress on mutual aid, but we need to do more. And I think, so we're redoubling our efforts with the acute provider collaborative support Oxford in terms of that mutual aid position to push them towards 65 weeks by the end of March. I think that's very high risk in terms of delivery, but I am confident we will see a downward trend moving forward. And last point on elective really goes to the piece around the elective care plan, just to give a flavour. So first headline of that is it's in 65 weeks, so 65% for 18-week performance next year on our route back to 92%. Just to give you a flavour of our differential challenge, RBFT are the highest in the region at 80.4% at the moment, and Oxford around 57%, BHT around 56%. Now, interesting, this will be an interesting debate for planning. The guidance says that each organisation has to improve by 5%. I think we may choose to take a system view on that discussion as to whether that is the best model for our population across the board. But interesting discussion. On cancer, we've seen mixed performance. We've seen a particular dip in this report from BHT in terms of 62-day performance around dermatology pressures. But we've also seen recently the Thames Valley Cancer the additional funding, just under £1 million, to support trusts with their recovery position in the last quarter. So again, I'm hoping to see an improved performance in Q4. Lastly, from me on mental health, so an apology. Those eagle-eyed may have realised that the mental health performance summary was not in version 1 of the pack, so apologies for that. That was an oversight from the team. We've got that in. If you updated your admin control, and it now should be in the website. There's no fundamental shift in terms of the performance against the key metrics there to highlight to board members, but apologies that was missing from the pack. I think I'll probably stop there. As always, happy to take questions, but perhaps Abby and Rachel give a flavour from your perspective.
So back to access from me. So primary care access in the first instance, all board colleagues may have noticed what looks like a dramatic dip in the 2-week standard for access for patients. We've done well all year and compared to national. So I think the analysis on this is that the total number of appointments has gone up significantly by 26%. So I think it's a numerator denominator effect. That's our conclusion. I think we need to track it over the next couple of months. But actually, if you look back, similar dip a year ago as well. So it's kind of went down to, but the volumes of patients seen have gone up significantly. Probably related to COVID, flu, RSV, all these other things initially working on. So I think something to watch and track. But we're doing all the other things in the detail underneath to help access, as previously discussed. On the flip side, for dental, further down in the pack can be additional wider measures, and you can see that we're tracking very well against access and unique patients accessing dental appointments. And there's a list of all the measures you see there, the detail. Some of that, Margaret, going back to the discussion we just had, some of that is what we funded from the reserve. So we've made sure we've invested in all those things above and beyond, make sure patients are getting the access and dentist. It's been noted certainly by region of all the things that we've gone ahead and done in addition to what we should be thinking. So it's always a moving feature to get handbags, and then you've got to commission more and you've got to try to keep. But I think overall the effect is really positive, and that shows in the good. Thank you.
A couple of things for me just to add and build on from what's in the report. So I'll touch on some of the work we're doing around developing our patient experience and improving that across the system. Then I'll touch on the work that we're doing around patient safety, which will include that reference to infection prevention and control, as I briefed on earlier. And then I will just talk a bit about the work we're doing in maternity. Finally, I'll add on just some latest data around our continuing healthcare quality performance, which, as Matthew alluded to, we've missed it out of the slide deck. So somehow with the automation of the P&Q report, there have been some bits that have come off. So we'll add that in going forward. And I wasn't quite as swift as getting those slides added in as Matthew has. So it's great that we've got Veronica in the room. And I think what you'll see in this summary is the work that we've really embraced from our Health Watch colleagues around people's experience of leaving hospital in Oxfordshire. And actually, for me, it reinforces the message we heard from Barbara right at the beginning of the session, which is around how people want to remain at home and in their communities rather than in hospital, and that we can see the positive impact that that's had on their health outcomes and their well-being. But we've seen through this that there is recognition around the work that we need to do to improve support and identification of unpaid carers. Again, that reinforces the message that Barbara gave us, and around clear communication with our patients and carers. So that's something that's continuing to be a focus for the team, particularly in Oxfordshire. Within the pack, you've also got a link to a brilliant exemplar of Luna's birth story, which summarises is, I think, a real illustration of how, when we collaborate across partners with the ICB and the Health Innovation Network, how we've made a real positive impact on some of the preterm birth optimisation care bundles that we've put in place to improve health outcomes. That without that work, baby Luna wouldn't be here to tell the story that we've heard today. So I will urge all members just have a look at that. And touching on what we heard earlier from Dan as well around some of the work that Oxfordshire are doing, we know the common theme coming through from complaints being received within the ICB relates to the ADHD pathway and assessment timeframe, and we know that we're doing work in how we reduce the impact of that and support those that are waiting. With regards to patient safety, the board will have heard now from me a number of times that we are embracing the new patient safety incident response framework. And as such, some of us will have heard through many of the media stories over the last couple of weeks, particularly the work that we're doing to support safety within our EDs. We did a big review with our colleagues at NHS England and are really encouraged by the work that our partners do to keep our patients safe within the emergency departments. And you'll have heard colleagues talk about corridor care, and I saw myself firsthand over Christmas the work that the trusts do to really minimise treatment in escalation areas, and particularly in corridors, and that is kept to a real minimum, and the risk around that is managed brilliantly. We've had no new never events, continue to roll out the PSERF positively across all our trusts, and looking forward to working with our colleagues in primary care as to how we start to roll out PSERF more broadly. CQC are being more present across the patch, and we welcome that. They were with our colleagues in Oxford Health just before Christmas. and they've been in one of our primary care facilities as well, and we're just waiting for those reports to be published. We touched on infection control earlier. We do remain marginally above the trajectory set by NHS England for those mandatory reflections, particularly around Clostridium difficile and some of those other key markers. But although we are slightly above, we are still below where many of our colleagues nationally are trending. And we know that this is a direct result of pressures in the system, so continue to work with them around lessons learned there. We are experiencing, moving into maternity and neonatal services, we are experiencing common cause variation in perinatal mortality and experiencing positive special cause variation within smoking rates at time of birth, which is a good indicator that the work we're doing around prevention and smoking cessation pathways is having a positive impact. Similarly, around breastfeeding rates as well. So again, you can really start to see the positive impact that our teams are making in those areas, and delighted that we are working with all three of our providers on supporting them to declare full compliance against each of the 10 safety standards in the maternity incentive scheme, which is a real positive, because that will mean we've got money then to reinvest back in our maternity and neonatal services. And then lastly, in relation to continuing healthcare, we continue to see improvements against the 28-day referral assessment criteria, which again is a real positive, and that is helping with some of the positive financial position we are starting to see. But what we are seeing is a shift in the conversion rate around our standard assessments for CHC, which is suggesting that particularly in Berkshire West and Buckinghamshire that we are finding that there are more people eligible for continuing healthcare compared to what we have seen previously, which within the context of the financial position we find ourselves in, the work that we need to do on reducing that variation and managing the contracts and how we commission our care packages is even more important. And we are working closely with our colleagues nationally to ensure that those fundamental standards are in place. So that was my long summary.
Thank you, very helpful. Sim, I have a question to you, sorry, you. Just in terms of mutual aid, you mentioned mutual aid, and I think Oxford UH could do with more. And that made me think about the acute provider collaborative, because that's one of the things that should be delivering that arm, if you like. where are we in terms of their maturity? Because we know we had a slow start. I noted that there was a recruitment going on for, is it a programme director for the APC? I saw it on LinkedIn. So that made me wonder, is there a better crystallisation of our outcome? Because if we're employing sort of more people to go into something that isn't functioning.
Well, I
thought, I suddenly thought this doesn't feel, well, it may be right. I just wanted the assurance really that actually this will add to the applicants rather than muddy the waters further.
Yeah, I can probably talk best about the role in elective recovery, because obviously they're doing some work around back office functions as well as collaborative. But the APC runs a mutual aid today. So it's quite interesting when we go to our regional meetings and they look at Nick and I for mutual aid, and I say, well, the APC run the acute provider recovery run the mutual aid process, and they do. So Naomi runs that. She has weekly meetings with the operational staff in the acute trusts. They identify the specialties that need mutual aid. They work through what is quite a complex process of identifying patients, transferring information, assessing them, and making sure they move across. They've also run a lessons learned from the temporary mutual aid for the first half of the year, and therefore a rigid process to get that right. So operationally, it's getting better. I think strategically, it's still not the right intervention to equalise wait times. So we shouldn't be focusing on moving long waiters. That's not the strategic solution. The strategic solution is to work together on some of the elective care hubs to do high volume, low complexity with a brand around it rather than a hospital brand, and to work with GPs in some areas to make sure they're clear on the inequity of pathways and actually how we can use GP influence and choice to try and equalise wait times across the system. Now, the APC have a clear plan for that over the next 2 to 3 years that aligns well. It's not like for like with the elective care plan, but actually aligns well with the elective care plan. So I still like to see, we'd all like to see mutual aid quicker, smoother, more straightforward than it has been. But I think I can see effort, focus, and process around it, and I will check the programme director on. Certainly not named. So I'll take that away.
Thanks, Priya. Thanks, Matthew and Rachel. Specifically on the report, I think it's on page 79 of 109 in our board book. It's the cancer, report. Again, trying to take a system approach, which is what we should be doing here, not looking at individual per se. Obviously, the system numbers dropped primarily because of Buckinghamshire Healthcare, which were quite dramatic, and they were already the lower performer. Again, not picking on them, saying how can we collectively across the 3 trusts for the residents of Buckinghamshire, how can we, what lies behind that? Because lower down on the same side, it says their diagnosis rate is actually improved, and the faster diagnosis went up. Yeah. But yet their actual performance on getting the referral went backwards quite a lot. Yeah. What lies behind it, and more importantly, how can we try and support and help?
So I think, as I mentioned, it was a particular issue around dermatology capacity for this period that saw that dip. To be fair to the trust, they did flag that there was going to be a substantial dip. There is good system working on cancer.
Was that people or was it equipment?
I think it was people, actually. Yeah. I need to double check that, Tim, because it's a while since I had that debate, given how structural data is. Yeah. Well, I think check that. I think it was a people gap. But actually, the Alliance facilitate joint working. But actually, what we've seen previously is actually the trust that are generally quite good at recovering under their own steam. Occasionally, there are inter-trust issues and mutual aid debates that need to go on. But actually, my expectation is that each of the trusts should recover back broadly towards target by the end of the year. And therefore, there isn't quite the sort of system imperative of mutual aid, where we've clearly got some embedded issues around delivery.
It's just that if you take that as an example, but that numbers are numbers and percentage is percentage, but that's a whole load of individuals who had a skin cancer diagnosis who are not getting referred. So
it's all well and good saying by the end of the year we'll be all right. Not great if you're one of those physical individuals who's affected. Is there not through either Thames Valley Cancer Alliance or more national, when we know there's going to be an issue in advance, like it sounds like is there not an opportunity to refer the person into London or to Southampton or to Northampton or somewhere? I don't know. I mean,
I think that's an entirely fair challenge. I think I'd have to take that away. I suspect it depends where you are in the pathway and whether a particular transfer at that point in the pathway is practical or the right thing to do for the patient experience. But it's a fair challenge, and I'm happy to go back just to check the point with BHT around what was the assessment. They knew that dip was going to happen.
Yeah.
Did they look at mutual aid as a possibility?
I'm not trying to labour this particular. It's more the generic point of as a system. Confirm on what we said this morning. How do we make a change and follow it through as a system? And it might even be out with our system for the good of the patient. If we know things are going wrong, or for whatever reason we're going to struggle, how do we address it?
Yeah. And I think I've probably got a number of examples where where the trusts do work together to address shortages, transfer staff and do support. But I can't answer on this particular one.
Appreciate that.
But I'm happy just to check around it. But I think the Alliance do a reasonably good job of trying to align that cancer specific. And I personally do think the relationships across our three trusts and operation are relatively strong actually. So notwithstanding some of the challenges on mutual aid.
For the action list for next meeting, could we just get a one-line update on that?
Yeah, on the
BHT, dermatology cancer in one paper, whatever. Just as a case study, really.
Yeah, happy to.
Yes, so the question for us is, what is our response to anticipatable risk materialising, and how do we make those judgments? Because the issue is not to adversely impact the outcome for the patient as a result of operational.
And particularly in this context where the trust is already struggling at 56%. So I'm assuming we're throwing everything at it already, so to speak, as a team. I'm going to, I don't know, just.
Well, let's speculate.
Yes, I'm often specific. So, but I'm happy to take that.
And this is super specialists and those sorts of single things that it'd be very helpful to understand how we respond in general terms. Any other comments? Sorry,
just reflecting on the update in relation to elected performance and some of the questions, particularly in relation to the chief provider collaborative, which I think is of fundamental importance in terms of how we're going to address the elective challenge. Particularly if you think about the variation of performance that currently exists between the three providers. We have one of the best performing and one of the worst performing providers in the region in terms of a lot of weights. I know the board has received updates regarding the provider collaborative in the past. I just wonder whether we need to think about scheduling another one, not least because there's a new chair. I think Professor Montgomery is now chairing the APC, so it may be opportune time, particularly as we go into a new financial year, just to take stock of where we're at, because I think it is performing more effectively than it was a year ago. Whether it is realising its full potential, I'm not entirely sure.
And that will come into how that feeds in on a regular basis as well, rather than a one-off question. See what these things are, because with all of this, how we identify the opportunity that is then addressed through the delivery through the APC, I think is part of the issue that as a board we will want to be sure is an evidence-based approach to those opportunities. Thank you, Nick, and thank you, Sim. Any other comments or questions in relation to the operational reports? Could we move now then to the emergency preparedness, resilience and response paper from Matthew? Thank you, Matthew.
Thanks, and I think I'll be relatively brief just to confirm this through Moderation Committee. I think last week we looked at the meeting of a process on its way towards full assurance. So this is an annual process in terms of looking at core assurance standards for both the ICB and also our provider trusts across the system. and you can see it's generally a positive, well, actually a very positive report, and demonstrates, I think, the work that the team in the ICB have done, despite actually all the resource challenges this year. So I want to give them credit to them on that. So it's an ICB, we are substantially compliant. That is a slight improvement from last year's position. And the only one that's partially compliant is command and control, which is training for our core staff. And before we take too much concern from that, just to reassure everyone that the core staff are trained before they go on call internally. The gap here is the availability of some of the 3-year courses of those 3-year courses for strategic commander training. So the team have got a plan to both get better access and encourage attendance from our call directors. We're honest that we weren't substantially fully compliant with that, but actually there is a clear plan and staff are trained before they're on call. 2 other points to note, really, I think Paul, who's our emergency plan officer, took a slightly different approach this year. He did some of the assessments together for the acute sector and the community mental health sector. I think that was, there was initially some concern about that, but I think actually post that collaborative approach, I think that was seen as positive in terms of sharing information and work across the system, so a more collaborative approach. And just to note that there was a cyber security deep dive as part of the process this year. Those ratings don't affect the compliance assessment of individual trusts, but as board members will appreciate, across the system, so the team in that space. That's probably all I wanted to say. I think you were asked to note our role within which is compliant to the system.
Matthew, do we know why PPR versus Berkshire Healthcare is hosted by Tribune?
No, I don't have the top of my head. You always catch me one.
No, I asked the regional lead this, he didn't know either. It just seemed, I was very keen that we retain them for other purposes.
Yes, it does result in a mixed message.
Yeah, it's strange. Yeah.
Retain them. No, I'm happy to check that.
I think, Matthew, it's fair to reprise the conversation at Audit Committee last week or so that we did flag a concern about that lack of training of on-call staff. And there was quite a conversation about the risk to staff who are on call without the full training, and also the possible risk to population if staff on call are not fully trained. And there was a comment about you just mentioned about the availability of training, and various people said that it wasn't for not wanting to do it. It just wasn't available in the system needed. Whoever's providing the training needs to kind of do something to speed it up and make it available that will suit people. So we did flag it as a risk in audit.
Yeah, I think to be fair, Margaret, it's a bit of both. So I think it's getting people to show interest and getting the gaps and aligning the two. I think Paul did follow up and following up with a note round to audit and remuneration committee. So I know he felt he didn't give that much detail at the meeting. So I'll double check that. But,
we didn't. I didn't get that.
Okay, so I think I'll follow up that, but he did talk through me the exact preparation we do give on call directors, which is part of the internal training. As I say, these courses are things that people need to undertake every 3 years as part of that strategic commander role. Absolutely, that's why we weren't substantially compliant, because we had to be open about some of those gaps.
So audit committee was satisfied that those undertaking the duties are sufficiently trained to do so safely, and that there is a timescale now in place for the mandated training so that we can be substantially assured. Is that?
No, we thought it was surprising that commanders were in place that hadn't had the training, is how it came across. And there was a combination of both people being put on call that were just happened to be the next available, as well as the training not being available when they were available to do the training.
I just need to correct that.
Yes, because I think
to be absolutely clear, nobody goes on call without getting training. This is particular commander training that is required every 3 years for people.
Okay, that's not how it was explained by
I accept that, and so what I'll take as an action is to have this conversation with you. Obviously, you fed back the debate at audit committee to me. So I had a conversation with Paul. It's outlined to me exactly what happens, and I'd understood that he'd gone back to audit committee members on that. Now, if that hasn't happened, I could just follow that up and see that extra assurance around to audit committee members, because that's the conversation.
Maybe we're going to come back to the
Yeah, no, that might be my misunderstanding, so I will pick that up with Paul.
Thank you very much. Okay, I'm going to move us then to our Board Assurance Committee update, audit and risk, people, place and system development, population health and patient experience, and system productivity. You also have the triple A's in your pack, other than those ones that are so close to our meeting today. So audit and risk and system productivity will be verbal updates. Can I ask then to start with audit and risk?
Yeah, the only thing that I was going to mention, and obviously we've already discussed about the EPRR, but the fact that we had substantially compliant has already been mentioned by Matthew, saying that was the result. We had some single tender waivers and there was a live contract, but that was kind of the process that it was going through. There was nothing untoward there. And on internal audit, we have 3 that under the old rating would have been classed as substantial. So risk management, core financial controls and primary care commissioning, they're now called significant assurance with minor improvements. But that was a good result there. And then, unfortunately, Claire Dover was off sick at that time. So the information governance update and policy process update will be brought back at our next meeting, which will be at the end of February. That's all I wanted to raise at this time.
Thank you. I'm going to get all of the updates. And so could we ask for system productivity next, please?
Okay, we didn't have a formal meeting. We had a workshop. We had a meeting, that was in December, sorry. We had a workshop literally a few days ago, which is why there's no written report. It'll be forwarded to the next board meeting, obviously. In terms of the overview, though, we obviously talked about the financial position, which we'd like was read. We've heard about that already today from Matthew. We also talked about digital, which was overall was an amber report in that it was some very good progress, good work being done on population health insights. And we get some more consistency across the whole system, which was good. The one area that was read within, and it's worth mentioning for the benefit, is around the IT infrastructure at RBFT. So there's a little bit concerned about the age of the. We understand that obviously RBFT are managing that themselves in terms of they've got their own audit and risk committee on top of that, but this board should just be aware. There's nothing we had at the assurance after some confusion over terminology. There's nothing that makes us feel anything Will Berkshire is going to fall over in terms of in immediate future. But it remains concerned that there's not yet. We don't have the visibility of a plan to have all that kit immediately, so upgraded quickly. But it's a known risk within Royal Berkshire, and they are managing it at that end. But the board should just be aware of that. And that's really the main elements to highlight.
Thank you. I'm conscious that we have a meeting immediately after this, which is a board to board. So we will stick to our timing, please. So thank you for your help with that. Could I ask then for people, place and system development, population health and patient experience in relation to those things over and above? Would you like to say? Oh, that's great.
Lovely. Very simple, but you'll see the red in there about the change programme and the people and the vacancies within that. I think we've discussed that well. So the mitigations are the meeting that's just been held and the phasing in of that recruitment against need and cost. So that then reduces the risk.
So the understanding that we wanted was of the substantive vacancies, what percentage is actually filled temporarily, so the work is being done, so it's not, and also how do those map across to areas of risk? That's what we've said. Yeah,
right. There's still risk even when positions are held as an interim because there's interim provisions are, by their very nature, sort of stop-start. So, there is always both by the time the litigation is in there. And just to assure, really, health and safety policy, we've been developing that, but it didn't really exist. It now, because all of us, we will continue to have it on the agenda so that we can make sure we have people we need to cover those areas. From a place point of view, just in terms of what some of the you see the policies that we're updating the policies, they're fit for purpose, and bereavement will probably go in there as well. Some people review that to see where we need to be. From a place point of view, you can see that the alert was around change programme and place. And I think Dan brought out today some of those questions that still are pending. Very much so. So we flagged those in the Complaints Committee. We also noted that the convening aspect of the ICB and some of the subcommittees, so we mustn't lose that in place either. So I think it's a continued work in progress as we change the governance model to make sure that this delivers and receives delegation. We also noted the risk of SECCOM, that we noted today. So it's come up again that it's very complex. It will need managing and to make sure we capture the risks, if you like, mitigate against those. It looks good on paper, but what's
great. So let's have our last, and then we'll come on to the discussion.
So yeah, population health. So we flagged 8 areas as a red alert. Quite a few of them towards the end are recurrent red alerts from previous committees, like monoways, the end of life care, respiratory diabetes, and so on. But the common theme with all 8 of them, won't go into them, they're all about funding pressures and staff resource, lack of staff. So that's we found this kind of wave increasing over the last year, and it's been identified in these 8 areas. We'll just refer to the first one. I think that was quite interesting conversation on mental health outreach services. So you'll see there for about 600 people in region where severe mental health illness, where engagement is a challenge. So very, very difficult, critical package of care for individuals. And I think the conversation in committee was interesting because were we assured that plans are in place? Yes, plans are in place. Are we assured that there's sufficient resource to meet the needs of those individuals? No. So yes, there's partial assurance, but not in terms of delivering the service and policy that we want to. And that really is the case for that important.
Thank you. Okay. Comments and questions then in relation to all of our subcommittee reports. I know that these have been discussed at some length. So I completely understand that the issues that we picked up during the course of our discussion have picked up many of these. So thank you very much. We've come to the end then of our agenda, and I'm just going to run around the table and ask, please, if there's any business. Thank you. Thank you all very much. I think as a board, we want to convey our thanks to the staff and teams who have really worked exceptionally hard again over winter and over the festive period as well. And also to those who are really pushing for some of these changing ways of doing things so that we are even now getting ready for next winter. It's very good to see. Rachel, please could we convey our absolute heartfelt thanks to Barbara and a wish that she stay close to us as we look at those areas that she so helpfully highlighted for us. Thank you, everybody, and let's close the meeting.